Welcome. And I know we had a little Zumba already this morning, so we're ready to go. I'm Lori Deitte. This session has a very long name. It's Teaching and Integrating Imaging 3.0 into Residency Training. And Eric England and I are moderators, and our speakers, I have the lineup. We have an all-star lineup: Lucy Spalluto, Carolynn DeBenedectis, Pamela Schaefer, Lenchik, and Tessa Cook. And this is our session lineup. So we have actually 5 speakers. So each one is going to be 12 minutes. And our goal then is to save time at the end for questions and answers. I would just ask that you check your cell phones and make sure that you have them silenced. And now we'll move into Lucy's talk.
Good morning. First, I have to thank my colleague, Dr. Stokes, who has done a tremendous amount of work in this area, who unfortunately couldn't make it today for the presentation. I'll be focusing on engaging residents in both patient-centered care initiatives and patient engagement. Today, I hope to, 1, define patient engagement, 2, discuss opportunities for patient engagement in radiology, and 3, discuss opportunities for residents to participate in patient engagement in radiology. So when we talk about patient engagement, a lot of buzzwords come to mind. We hear the words patient engagement, community engagement, activation, patient-centered care, patient-centered outcomes research. These all mean slightly different things and are all very important. For example, activation is increasing an individual's knowledge, skill, and confidence in managing their own health and healthcare. Patient-centered care is building a partnership amongst practitioners, patients, and families to ensure the decisions that are made represent the patient's wants, needs, and preferences. While patient engagement is a little bit different, this is actively forming partnerships between patients, families, patient representatives, and health professionals across the entirety of the healthcare system in order to direct care, change organizational design, influence research, and influence policymaking. So how can we do this? What forms does patient engagement take? Lots of different forms. It can involve involving patients in the research process, all the way from research design to implementation of studies to dissemination of results. It can involve talking directly with patients and their families about their experiences and how these might be improved. And as you can see, both of these can be directly related to patient-centered care initiatives. So why is this important? Why would we want to involve patients in the research process? Well, PCORI, the Patient-Centered Outcomes Research Institute, has research proving that involving patients in this process can influence outcomes. So if we focus on the outcomes, the actual act of involving the patients can change the culture of research and build meaningful and effective partnerships. It can make research more useful, research that patients want done, and research that will change the quality of their health decisions. And in the long term, this will create a more optimal healthcare system. So how can we engage patients to influence organizational structure or the patient experience? At our institution, we have formed a patient advisory group. We asked our lead technologists in CT, MRI, and PET to recommend patients they knew through multiple encounters in the department. We also actively sought out patients who had expressed concerns about the care they had received in radiology, and these potential members were contacted to gauge their level of interest, and a formal letter of invitation was sent to join the group. All patients who were elected to join the group were enrolled as official VUMC volunteers, and departmental members of the group included the department's Quality and Patient Safety Director, the Administrative Director for Radiology, a Radiology Patient Experience Manager, and a Radiology resident. The mission of this group, our Patient Advisory Group, was to build a partnership between our department and the community we serve, to promote a culture of patient-centered care in our department, and to focus on the concerns of patients and their caregivers to improve the quality and safety of patient care. In our meetings, we really wanted the patients to be comfortable. We immediately set the tone as a comfortable place for open discussion where their comments were valued, and where we openly welcomed criticism of the department. We met in a pleasant environment that was convenient for the patients, including both parking, walking directions to the meeting area, and a comfortable table to sit around. We also served a meal that was easy to eat while talking, and we joined them in the meal. We specifically always include more patients than physicians in the meetings so that the patients do not feel outnumbered. And we always include a senior level administrator so the patients feel that the power to institute change is present. We also designate an administrative assistant to serve as a coordinator for the meetings so the patients always have someone to reach out to by email or phone if they have questions. There are lots of opportunities for resident involvement in this patient advisory group. We include a resident as a member of the patient advisory group. We can use the suggestions and the feedback from the patients as a starting point for quality improvement projects that the residents can be involved with. We encourage residents to take advantage of opportunities to engage with patients during examinations or consultations. And we have had a panel discussion with the patients who are willing to share their experiences so the residents can gain a different perspective about what it is like to actually be a patient in our department. This is a picture of what one of our standard Vanderbilt Radiology Patient Advisory Group meetings looks like. As you can see, it's a round table discussion. There are more patients than hospital employees, and the patients are comfortably eating their dinner, having their drink, and participating in the group discussion. If this works, this will be an example of some of the patient feedback that we've received from this group.
My experience first was, and you guys will probably remember this if you had MRIs down there. You walk in and you take a number, like a pull tag, at a DMV. It was that kind of thing, the old fashioned. Wasn't a good feeling. You know, you got this number and you automatically think, I'm a number. Well, that's kind of how it started. And then your name is called and you go up to the window and they make sure your insurance information is correct and everything. And the person I was interacting with was concerned with lunch and lunch plans and was making lunch plans with their coworker and not engaging in what was going on with me. So that was the second thing. And at that point, I was like, okay, she's not really engaging in what's going on. So you go on, and from there, I was called back and to a room to change, and put in a room with another gentleman to wait in a gown. So that was uncomfortable, and then the tech came in and asked questions that were personal in front of another patient. And it was like a snowball effect. That was a bad experience. And then I was asked to join this group and express my concerns, and went for an MRI probably 6 months after that experience, and it was wonderful.
Okay, so as you can see, the patients have lots to say. They're not shy. They're happy to share their experiences and how we can help to improve them. So through this group, we have heard many patient concerns, and we have developed many departmental initiatives to address these concerns. A main concern was that patients frequently experience delays in scheduled examinations. To address this concern, we have improved communication with patients regarding wait times. Senior staff are now expected to give routine updates to patients who are waiting on the status of delays. And we have improved scheduling with an increased effort at identifying issues with insurance conflicting appointments that can be addressed prior to patient arrival. Patients are also now given more options for different scheduling locations. Another issue was that patients do not always feel welcome in the department. They had that feeling like they were at the deli counter, grabbing a number and waiting in line. So now we have an actual person waiting to greet them with a smile and a friendly hello, who can help them through the check-in process and help direct them to the appropriate area of the department. Patients would like more information about what to expect during radiology exams, and this was actually a great opportunity to involve our residents again with engagement and with dealing directly with the patients. Our first-year residents completed a quality project to address this concern and extensively updated the patient information area of our website. One of our first-year residents was also invited to attend one of the advisory group meetings to show the patients the revised section and to gain feedback for additional suggestions on how we might further improve this section. Another issue was that patients would be interested in meeting with a radiologist to review imaging findings and results. And we are currently developing a diagnostic radiology consultation service that will allow patients to schedule an appointment with a radiologist. And again, we can involve our residents. A resident will have the opportunity to rotate on this consultation service, giving them another opportunity to interact directly with patients. Another opportunity for resident involvement was having an advisory group panel discussion. We had a panel discussion held with 3 members of our advisory group during a normally scheduled resident noon conference. Each patient was asked to share something about his or her best or worst experience in the department and to talk about what serving on the advisory group has meant to them. And the residents were given the opportunity to ask questions of the patients on the panel. So in summary, formation of this patient advisory group for our department has been an incredibly rewarding process. We have learned many things from the patients that we never would have come up with from ourselves. We have developed many initiatives to improve patient and family-centered care in our department. And the group provides numerous opportunities for residents to become involved in patient engagement. Thank you.
Thank you, Lucy. And I would just say personally, walking by the greeter, instead of, well, so patients used to have a number. They take a number, like you're at the deli. So having the greeter there, that greeter does more than greet patients to radiology. They're frequently, asked to say, where is this, where is that? And so they're helping them navigate their way around the hospital too, which is a big benefit. Okay. Next is Carolyn, and she's going to be talking to us about the consultant radiologist.
Hello, good morning. So as she said, I'm Carolynn DeBenedectis. I'm from the University of Massachusetts, and I'm going to be talking to you about the consultant radiologist. So I have no disclosures. So why should the radiologist want to be a consultant? I think first of all, and most importantly, it adds value to what we do. It increases our job satisfaction. It makes us feel like an integral part of the team. And with physician burnout being so prevalent, this is a really important thing for us. It's also to allow patients to see what we do and how it adds value to their care. A lot of patients still think we are technologists, that we take the x-rays. They have no idea what we actually do. And if they can see that we read the x-rays, that we advise referring clinicians, that we make the diagnosis that helps them be treated, they can see how much value we add and actually know what we do as physicians. It's also to allow the referring clinician to see what we do and how we add value to the care of their patients. We all know that by consulting with our clinician friends, we can sometimes change the patient outcomes as well as change the course of treatment and even come up with a better plan for the patient. So it benefits everybody, and essentially, radiologist as a consultant adds value in all aspects of patient care. So how can a radiologist be a consultant? Well, we can be a consultant to referring clinicians and other providers, but also a consultant to the patient. So let's start about talking about the radiologist as a consultant to referring clinicians. So one great place that we can serve as a consultant is multidisciplinary tumor boards. Now, breast imaging is considered the archetype for this. As you all know, we review all the films before we go to breast interdisciplinary tumor board. We show up, we tell them where there's a mass, if they need a second biopsy, and we can sometimes change the course of what's going to happen to the patient. We can say, there's another mass, and that can be the difference between a lumpectomy and a mastectomy. So it's really important. And then there's all sorts of tumor boards in oncology now. And at our institution, we actually have an oncologic imaging division where we have a division director who actually, as a team with the oncologists, radiation oncologists, and surgical oncologists, ask, what do you want from tumor board? How can the radiologist help you? And then she in turn says, here's what the radiologists need to be more effective at tumor board. And that really helps to get the patient the best outcome. You can help on rounds. I remember as a resident in pediatric radiology, the pediatric ICU team coming down and rounding on PD films. I remember doing that in chest radiology as well. So that's a really great way either to have the teams come to you, or even you can round with the teams. You can send a resident up to the ICU to round with the ICU team and pull up the chest x-ray or chest CT on the PACS system up there. So a really great way, again, to get involved with the referring clinicians. And then one-on-one consultations, in person or over the phone. You can discuss imaging findings, radiation risk, or appropriate imaging studies. I think this is really key, and this sometimes is where we're the most useful. I know I always say to the breast surgeons, I say, why don't you come down and review that with me? If they call me with a question, let's do this together. Let's look at it together so you can see why I'm telling you I don't think a needle localization is going to work, or something like that. And I think it can really change the clinician's perspective, and it makes them see that what we do is vital and that we care. Because a lot of times they can sometimes think we don't care, that we sit in a room and read X-rays. And when they say, no, I really feel strongly that I think this is going to affect patient care. Can you come down and read this with me? They realize you're willing to take the time out of your day and that you really care about the patient. It changes their perspective of you, and it increases their level of respect. And it also increases their likelihood to communicate you and help you be more accurate. So, again, how do we do this with the patient? So we can be a consultant radiologist with the patient. We can review imaging studies with the patient. I know I have done this in breast imaging all the time. We have a PAC station in the consultation room. We'll say, this is the mass, and I'll show you some examples of that later. I did it when I did OBGYN ultrasound, and we did the ultrasounds or even obstetrical MR. So there's lots of opportunities to review the imaging studies with patients, and patients want this. This is, as Dr. Spalluto said in her talk, that's what the patients want. They want to hear from the expert on the imaging study what is going on in their imaging study. So a lot of places have started these radiology consultation clinics to tell the patients in person. Now, VIR and breast imaging have done this for many, many years. It's the standard of care. It's very common. We do it less formally, but we do it in pediatric and OB ultrasound, as well as in general ultrasound, because the patient's right there as the physician scanning. So we can show them on the screen, especially I remember when I did OB ultrasound, oh, look, it's a girl, or this is the abnormality we're seeing, here's why. And now a great new opportunity are these screening studies. The one that I see the most is these lung cancer screening studies, where you can review the study and then review it with the patient, but also CT colonography is an opportunity for this. So these are just some examples of when you pull a patient aside. You're telling a patient you have a mass in the breast, and the patient's going, oh, it's not going to be, I'm not worried, it's not going to be cancer, and I don't really want the biopsy, I think everything's fine. And this is a great opportunity to pull the patient aside and use the imaging and say, if you see a perfect circle, we're not concerned about masses like that, but do you see your mass is irregular? And you can actually show them. And patients, it's completely changed their minds. And I've had patients who went from not being willing to have a biopsy to actually being so grateful I showed them this, having a biopsy, catching their cancer early, and it be a great thing. So the power of the image is a lot, and to show them that and to talk to them and explain it to them well is a great tool. Pediatric ultrasound's another example. You're in there scanning, ER patient comes in, right lower quadrant pain. You're scanning the patient, mom's sitting there with the patient, and you can show her, here's the reason that we think your son needs surgery. There's a big dilated appendix, it's hyperemic, and the picture can help them a lot of the times. Again, this was a case I did in OB ultrasound. I scanned a patient, and we saw a sacral mass. We then talked to her about it. We then had her come back for MR. After we reviewed the MR, we had her sit with us, and we went through the MR images and told her it was a sacrococcygeal teratoma. And we could show her the findings, show her how it was what it was and what the management would be. And it lessens patient anxiety and increases patient satisfaction. Lung cancer screening is a really new place to do this, and we have an AVID lung cancer screening program. And, a picture's worth 1,000 words. You sit down with the patient and show them that mass. It's clear that that sticks out. And someone that might have, again, been shying away from a biopsy might be much more convinced, and they can ask more questions like, how big is it, and, where is it? And it just helps them a lot more understand their care, and they're much happier, more satisfied. So another really great place for this is reviewing cancer staging imaging studies. Greater than 70% of cancer patients want this. I know my mother and my best friend are both cancer patients, and they love that where they go for their imaging studies, they get their imaging study, wait about half an hour, and then they get to talk to a radiologist and know, is there recurrence? Is there not recurrence? And actually where they go, they get to actually meet with their oncologist and the radiologist to go over the study, and they really like this. And this is occurring at their cancer center as well as many other cancer centers around the country. And this is saying, especially with high anxiety of cancer recurrence or what's going on with your cancer, it's a really great way to help patients have a better experience. And then discussing patient questions about their imaging reports over the phone. I do this all the time, especially at one of our offices, where patients call all the time to talk about it. I had a patient call the other day because I read her screening mammogram, it was negative. And she then later felt like she should have mentioned a lump she felt. So she called to ask, are you sure there's no mass there? and you know, it made her feel better. She even said, it's for my psychological well-being. I know you said it's negative, but I really need to ask you one more time. And it just made her feel better. The other reason that we need to be a consultation to patients is we used to use PCPs and referring clinician as our proxies to answer questions about imaging. The biggest problem is they're not experts on imaging. As imaging has become more complex, they don't actually know how to answer the patient's questions. They're just not equipped to do it. So we can do that and help them in a much easier way, either by explaining the questions the patient has to them and they talk to the patient, if that's what the patient would like, or us talking to the patient directly. And then these consultation clinics that everybody is starting to think about and use are educational tools. They're great ways to educate patients about radiology studies, about excess radiation, and debunk some myths, or even maybe inform patients better than they are already. As I said, patients want, 81% of patients in a recent study said they want immediately results and perceive value in consulting directly with radiologists. So we're really concerned about patients valuing us and reimbursement and all of that, and this is one way to do that. So what are some issues with consultation? Time, okay? Studies are sitting on the list while we're doing the consulting, so that's an issue. Reimbursement. We don't get reimbursed. There's currently no fee for us to counsel patients or clinicians. So that sometimes can get in the way of, you might have added tons of value and done tons of work consulting with patients, but your RVUs are lower because that was time you couldn't be reading. It disrupts the workday. You know, you're reading screening mammograms or something that in a closed setting where you're focusing, and then someone interrupts you and you lose your focus. Does that mean you might make a mistake? And again, we talked about it decreases your efficiency sometimes. However, if you do it right, your efficiency wouldn't be decreased. If you give succinct answers to people and you do it often and you get practice communicating with patients and clinicians, you're going to do it more effectively and it's not going to take as much time. One big concern of referring clinicians is, are we overstepping our expertise? Their biggest fear is we're going to tell the patient something and then they're going to have to backtrack on it. And that's why, you know, I train my residents in how to communicate with patients and clinicians. And the big thing I say and stress is never overstep your specialty. The patients always ask breast imagers, am I going to need a mastectomy or a lumpectomy, right? Well, I can't say that for sure. But I'll say, you know, a tumor this size, if it's the only tumor in your breast, most likely can be a lumpectomy. However, I'm not the one that can make that final decision. Your surgeon will have to. So always defer to the referring clinician, and we should try not to overstep our expertise. What are the benefits of consultation? You may get more pertinent history, make your report better. We get more job satisfaction, find it more personally rewarding. I know the days that I make a patient's anxiety less or get a hug, it makes my day seem much better than sitting in a dark room reading x-rays. You feel less isolated, like you're not just a radiologist in a dark room. It helps clinicians better care for their patients, especially in oncology. We make a big difference in oncologic patients' care when we collaborate with the team. It improves our reports. Sometimes we don't even know we're not clear, and it can help us realize that. It gets us to know our non-radiology colleagues better and even facilitate. I know I've done a few research projects based on consulting with clinicians. Again, this is a big push. We have patient family-centered care through the ACR, RSNA cares. We really want to focus more on the patient being the center of care in radiology. So how do we teach being a consultant in radiology to your residents? You want to model the behavior, so you want to do it. If they see you doing it, they're going to do it. Have them participate in gram rounds and tumor boards. Have them observe you consulting with patients and referring clinicians, and encourage them to do it on their own by sending them to rounds only, not the attending physician when it's a simple thing. Also teach them communication, interpersonal skills. At my institution, I have a whole curriculum of simulation where they learn how to communicate and talk with patients. So in conclusion, consulting with patients and referring clinician improves patient care, increases patient satisfaction, increases radiologist job satisfaction, can in most cases improve radiologist accuracy, if done correctly does not have to affect efficiency, and needs to be taught as the standard of care to residents. And most importantly, it adds value to what we do. Thank you.
Thank you. Next is, I have Pamela Schaefer, who's going to be talking about communication with patients in person and radiology reports.
All right, so we're going to talk about patient perception of reports, models for improving reports, barriers to radiologists directly communicating results to patients, based on patient preferences and referring physician preferences, models for direct communication, teaching trainees, and some final thoughts. So let's talk about reports. And a recent study showed that over 50% of patients are reviewing their reports online. So what are the patient perspectives? Dr. Gunn and others in a recent JACR article interviewed 104 patients, and they assessed 104 patients who evaluated 8 reports, 2 radiographs, ultrasound images, CT and MR images, and gave feedback. Their comprehension, they had to rank their comprehension on a scale of 1 to 5. The median comprehension was 2.5. Why was it so low? The biggest reasons were unclear or technical language, jargon, and they were too long and there was too much detail. Johnson, in an earlier report in JACR, led some focus groups, and they loved the immediate online access. It allowed faster access, better preparation for their next MD visit, decreased delays, better self-education, self-empowerment, a lot of good things. However, they thought the reports were difficult to comprehend, they needed more appropriate detail, and they needed to be relayed in lay language that they could understand. So to address that, Cook et al. Worked on this research project where their purpose was to evaluate a patient-oriented radiology reporter or porter system, which was a web-based application to annotate reports. So over a period of 7 months, they took knee MRI reports and they annotated them with patient-oriented definitions, anatomic illustrations, and hyperlinks to additional information. And out of over 1,100 patients, 16% opened the ports in the viewing portal, and 65% of those viewed different annotations, like 28 terms over about 4 minutes. 22 patients completed the survey, and 77% felt that the definitions helped them understand the report, and 91% said that the illustrations were very helpful. So as an example, this is a report of a left knee radiograph, and the term medial collateral ligament was in it. So if you hovered over it, it would define it as a ligament in the inner side of the knee, and it would link it to this illustration that clearly illustrates the medial collateral ligament. What about embedding images in reports? Mangano et al. In an AJR article revealed that 89% of patients wanted images in their reports if it was abnormal, and 64% wanted images in their reports if the study was normal. Nayak et al. Interviewed 142 referring physicians, and what they said about embedded images was that it would improve the quality of interactions with radiologists, the referring physician satisfaction, patient care and outcomes, and that it would enhance the understanding of a text-based report. Sadigh et al. Took this one step further and experimented with multimedia-enhanced radiology reports and interviewed 200 referring physicians, or let them use this system. Overwhelming majority said it would be an improvement, improve their understanding, provide easier access to images while monitoring disease progression, that there would be increased likelihood of preferentially referring patients to facilities with this multimedia enhanced radiology reports, and that 2/3 were more likely to provide patients access to their reports and their images if they had this. So what exactly was this? So here's an example of a chest CT, and there's descriptive language describing nodules, and there's a hyperlink to show the nodules and how they're measured, and then there's another link to show basically the changes in sizes of the nodules over time. And I wanted to share with you this open letter describing what we should include in our reports in the era of patient web portals. So first of all, we should elicit full history. It reinforces that the radiologist cares about the patients and knows the patient in detail. We should use structured report templates, quantitation. They should be more consistent and accurate. We should avoid jargon. We should convey uncertainty forthrightly. Avoid vague reports about equivocal findings. Avoid might be consistent with. Describe patient behavior thoughtfully. Be non-judgmental. Say the patient was unable rather versus refused. Be sensitive, but don't unduly avoid sensitive topics, for example, weight and sobriety. Some patients are motivated to change. make evidence-based recommendations, avoid non-indicated studies. Non-indicated studies disregarded by the ordering physicians generate tension with the patients and the radiologists and the referring clinicians. Document all direct communications and proofread. Spelling errors signify carelessness. What about communicating directly to patients? So Dr. Mangiano and al. Also performed this study where their purpose was to ask patients their preferred method of receiving radiology results. And if the results were abnormal, only 25% preferred to talk to a radiologist either over the phone or to meet with the radiologist directly. Approximately 70% wanted to speak with a referring physician on the phone or directly meet with them. If the results were normal, only 15% wanted to speak to a radiologist, 50% to the referring physician, and 25% were happy seeing the reports via snail mail or online. So why do they prefer the referring physician over the radiologist? There's greater familiarity and comfort. The referring physician can place the results into proper clinical context. He or she knows the patient better. There's an inability to identify a radiologist as a physician, and there's a lack of awareness regarding the radiologist's role in patient care. So how do we improve upon that? This is a study performed by Miller, Gunderman, et al., where they had 307 patients undergoing chest, abdomen, and pelvic CT examinations. And 50% of the patients met with a radiology resident prior to imaging, and they were group 1, and 50% did not meet with a radiology resident. The resident defined a radiologist, including what their training was, that they'd gone to medical school, and they were experts in imaging. And they explained that a technologist would take images and the resident would interpret the exam and render a report within 24 minutes. So they spoke to the resident for about 5 minutes. In the pre-imaging survey, only 54% knew that a radiologist was a physician, and 64% had little to no understanding of what a radiologist does. For the group that met with a radiologist afterwards, 91% thought meeting with a radiologist improved their understanding of a radiologist's role. 52% thought it improved the quality of patient care. Group 1 versus Group 2 showed much higher much higher percentage of patients who thought the experience was better than their most recent prior visit. Higher percentage were interested in receiving a report from a radiologist, and a higher percentage were interested in going to a website and reading the biography of or biosketch of the radiologist who read their report. What about other patient-centered clinics? Dr. Mangiano from Mass General set up a diagnostic radiology consultation clinic. And in this paper, 22 patients in this clinic saw their primary care physician first and then saw a radiologist. And these patients had chronic diseases like atherosclerosis, emphysema, and hepatic steatosis. When they consulted with the radiologist explained again that he or she had gone to medical school and had undergone extensive training to be an expert in imaging. And then the radiologist would also review the patient's imaging studies with emphasis on the meaning of the findings and known modifiers. For example, he or she would review a chest CT and say this is emphysema, and it is related to smoking. There were no recommendations or no finding patients at fault. The results were astounding. The mean experience rating of the patients was 4.8 on a scale of 1 to 5. 100% would review the scans with the radiologist again. 82% after versus 41% before the consult preferred radiologist involvement. 95% versus 86% were comfortable hearing normal and abnormal results from a radiologist, and 100% versus 77% before understood the radiologist's role. So what about the communication of results to patients by radiologists? What did the referring physicians think? These were two studies performed by Gunn et al., where they asked primary care physicians and ED physicians who should deliver examination results. And both groups said, over 90% said, the PCPs said that they should deliver the results, and the ED physicians said that they should deliver the results in over 90% of cases. In the other 5% and 8% here, they said that patients should read the results online. Both group, there was 0% in both group who said the radiologist should radiologists should directly communicate the results to patients. So how do we get about that? We have to have coordinated care systems, and here's an example that's been very successful that I'd like to share with you. And this is a lung cancer screening at Hoag Memorial Hospital Presbyterian, where the radiologists directly communicate the findings to the patients before leaving the department. And they have 3 form letters, and they did this to standardize the message to facilitate communication. There's the study's normal. The second letter is there's a likely benign finding, but it requires follow-up. And the third one is that there's an abnormality. Basically, these are the 2% of patients with lung cancer. There's an abnormality that needs immediate attention. So with that letter, the radiologist always speaks to the patient and talks about the findings, but they also have expedited communication with the referring physician. They have an encrypted text message to the referring physician. The referring physician can access the images on his or her iPhone or other device. They immediately schedule an appointment with the referring physician, and they immediately hook up the patient with a lung cancer nurse who can make an appointment with an oncologist. So immediate coordinated care to the referring physician and the patient, and all of the parties are happy with this. In addition, the radiologists continue to educate the referring physicians and keep them up to date on lung cancer screening recommendations from radiology societies such as the ACR and the Thoracic Society of Radiology. What about teaching trainees patient communication? How do we do it at MGH? It's important to make it front and center. So for example, in breast imaging, they put it in their curriculum objectives to show proficiency interacting with patients, how to recommend biopsy, explain cancer diagnosis, and develop sensitivity to patient emotional needs. Attendings model effective communication in multiple settings, at the bedside, in the clinic, and during procedures. It's very important to have fellows and residents with them as they model this behavior. In daily IR and patient rounds, daily IR clinic, IR during IR and other procedures, especially explaining complications, monitored CT and MR exams. In the breast imaging group, faculty join the trainees for the ultrasound when findings and biopsy recommendations are made, and at the time of biopsy when they talk about biopsy results. In neuroradiology, we're embedded in a neuro-oncology clinic where sometimes with the neuro-oncologist, we and the trainees speak to patients. During daily imaging rounds, in breast imaging, in addition to going over interesting cases, they discuss challenging conversations and patient interactions. And also, many sections at Mass General use journal clubs and didactic lectures to go over important articles discussing patient interactions. So I'm just going to go over one of those, and then we'll sum up. For example, in breast imaging journal rounds, they talk about breaking bad news, a primer for radiologists in breast imaging. This was written over approximately 10 years ago, but it gives specific steps and examples on how to communicate with patients. Provide a private location. Have a follow-up appointment available. Disclose the news. Start with a warning shot. I'm concerned about what I see on your mammogram. Give the information in simple terms. These look like sand on the mammogram and can be the earliest finding of breast cancer. Gauge the amount of news the patient can cope with. Different patients have different levels of understanding. Evaluate the patient's response. Allow the patient to express their concerns. What are your thoughts and concerns? Provide empathy, provide support, provide follow-up. And this is just another example of a journal article, which I'm going to skip over because we're out of time. So in conclusion, it's imperative that we as attendings do this, and that we teach our trainees to improve their reports, make them structured, evidence-based, concise, have no jargon, embed images and graphs that helps the patients and referring clinicians. Embed trainees in primary care and oncology and other clinics. Have them talk to patients directly. It will improve their care. Teach radiologists to patient communication skills. Include these in your curricular objectives. Model effective communication in clinics, at the bedside and at the scanners. Discuss patient communications during your daily rounds and in journal clubs. And participate in coordinated care pathways. Coordinate communication of imaging findings and biopsy results from the radiologist to the patients and referring physicians, and from the referring physicians to the patients. It will be a rewarding experience, and it will vastly improve patient care. Thank you very much for your attention.
Thank you. And next we are going to hear about research ethics in the 21st century. Leon Lenchik.
Good morning and welcome. It's always a pleasure to give a radiology talk without any radiology images. And the reason is what I'm going to talk about transcends radiology and really applies to all specialties. And in fact, we give similar talks to non-radiologists as well. So if you go to the AUR website under resources, you'll see this collection of vignettes prepared by Andy Rosenkrantz that addresses in very concrete terms all the various issues around authorship and research ethics in general. So since my assignment is to talk about authorship, I kind of picked one of these topics, which is author order, because that seems to be, in my 20 years of writing papers, the most divisive issue and one that can really create a lot of hostility among radiologists and non-radiologists. And I'm going to try to suggest on how we can convert that to a more satisfying issue. So probably everybody in this room has been in this situation where they thought they deserved to be first, but ended up somewhere else on the manuscript. Somebody else deserved to be nowhere on the manuscript, but ended up there in the first place. Or you did the work and somehow the PI excluded you, or somebody else did nothing and somehow they got included. So I'm not going to ask you to raise hands, but since I'm clairvoyant, I'm pretty sure all of you have been in one of these situations before. So here's a case example from my life. So a junior radiologist in my section worked on a case report with a surgeon where it was pretty much their idea because the case came through imaging and they did all the literature search and helped prepare the report. The orthopedic surgeon submitted it to an orthopedic journal that had an author limit of 7. And the radiologist was then contacted and said, how would you like to be in the acknowledgement section? And instead the surgeon included the team trainer and the physical therapist as the author. So myself being the senior radiologist in this example, had to gently point out to the orthopedic surgeon that this is not how we do authorship. And I was able to resolve the issue, but as you can imagine, there was some erosion of trust between us and that particular surgeon, which is unfortunate. So if you look at the guidelines from the International Committee of Medical Journal Editors, there are 4 criteria for why you should be included as author on a manuscript. So obviously you have to do substantial contribution to the experiment, but you also have to draft or somehow be involved in the manuscript. You have to somehow be involved in final approval. And more importantly, you have to own the data. In other words, you have to be in charge of the integrity of data, and that's not a small feat. So going back to the AUR website, this determination of author order, if you click on this, you get this kind of a vignette. I'm not going to read it to you because we only have 12 minutes. But it basically gives you a real-life example of what can happen and ideas on how you can solve it and references. And if I can give you the Cliff Notes version of this, the ideal scenario that the project director or the PI the culture that that person would instill would discuss the authorship issues at the onset of the project. Since projects very frequently shift in scope during their duration, that PI should be flexible. They should do periodic check-ins with the authors, and the process should be fair and transparent. So that's the ideal world. I've been doing, again, this for a very long time, and I have yet to encounter an ideal type of scenario. But this kind of scenario I've encountered many times. So typically what happens, as all of you who do research realize, is that the project leader or the PI is focused on results, right? So typically most of the conference calls, most of the in-person meetings are spent discussing tasks, divisions of labors, deadlines, and frequently, especially when the project evolves in unexpected directions, the check-ins are used to kind of adjust the project, less so than talking about who's going to be an author on which paper and when. And frequently, the process may seem less than fair and less than transparent. So let me share another example from my life. This one I'm calling blind ambition. This happened to me in the past few months where I was the lead. It was a multi-center study. One of the co-investigators called me to check in. And what the check-in really looked like is the person complaining to me about the amount of work that he was doing, the deadlines, the stress, the burnout, whatever you want to call it. And somehow the conversation drifted in him wanting assurance that he would be first author on the main outcome paper, which I thought was a little bit unrealistic. So I tried to employ meritocracy and say usually author order is determined by relative contribution. Usually it's determined by project director. I offered him ancillary projects and ancillary papers. And what he did instead is then hold my data hostage, where we nearly missed an abstract deadline because he was being passive-aggressive about it. So perhaps he won the battle, but I can guarantee you that my interest in working with him in the future pretty much went to zero. So I think he lost kind of the overall human relations interaction. I'll give you another case example from my life. This one is almost an identical example, but since I was on the other side of it, I'm calling it mission creep because I'm not going to call myself as being blindly ambitious, right? So in this case, I was asked by a very well-funded basic science investigator to help with an R01 submission. The proposal got funded, but my percent effort went from 10% to 5%. I thought this was completely unacceptable because I'm so important and I was doing so much MRI reads that despite multiple conversations, we essentially were not able to resolve the issue. He outsourced the MRI reads to Europe. He ended up publishing the paper in JAMA. I was nowhere near on the manuscript, but instead some random radiologist that had nothing to do with the paper, not the European, but somebody completely different ended up on the manuscript. So I see that as a lack of judgment on my part, but more importantly, since we both still work at the same institution and we still both have research interests that overlap, this stupid kind of move on my part basically prevented future collaboration. So who's to blame for this? So I think I alluded in my last two examples that certainly people are to blame, right? We're all making decisions based on how we interact with other people. But you can also make an argument that institutions are in part responsible, and maybe even journals. So this kind of publish or perish productivity quotas, I think can potentially be a sign of institutional ambition. And I've had people tell me as late as a few weeks ago that my department expects me to be first or last on this project. And I said something, well, that's very nice, but where am I supposed to put the other 10 people whose department chairs also expect that? So it's very difficult to solve these things. And in my view, this kind of institutional pressure or institutional ambition can be as dangerous as personal ambition that I showed you earlier. And I think it limits opportunities for us, and it's really bad for science. Well, what about journals? Some journals have author limits, and in my view, author limits are really kind of arbitrary and unrealistic because as radiologists especially, we're always looking for collaborations with non-radiologists. And it's really, you know, I've had to write many letters to journal editors trying to explain why this multi-center study deserves to have more than the limit of authors. So I think that needs to be rethought. But on the positive side, I think that when journals ask you to explain each author's contribution to the paper, I think that's very healthy. I think we should avoid giving people a free ride. I think we should encourage people to change the culture and not put their wives or, children on papers and, their secretaries, but instead put people on papers that actually contribute to the project. So I think that move on the journals is very well and past due. But really, if you think about the journalist perspective, I think author misconduct, in particular self-plagiarism and old-fashioned plagiarism, are really a much bigger issue from the standpoint of an editor. And if you look at my favorite editor, Tom Berquist, that just put his name into PubMed and pull one of his editorials, I mean, really, most of the issues around AJR misconduct, and I can guarantee you it's the same thing with radiology and with non-radiology journals that I'm part of, it's really this issue of plagiarism more so than this issue of author order. And in fact, the journals couldn't care less whether you end up being first or last. They just want to make sure that you're part of the study. So how do you turn this divisive issue into something more satisfying? I think one way to do it is to focus on science rather than on individuals. Find projects that you're passionate about that advance the science. But also, another way to make it satisfying is to flip side it and say, well, human relations matter. So you don't want to be like that person who won the battle but lost the war, because you need to be working with these people for a long time, and you need to give them benefit of the doubt. You need to think that the PI is well-intentioned. And don't sweat the small stuff. If you love your work, I think eventually you'll be rewarded. If not on this article, then on the next. And in my experience, and I've been doing this for a long time, my most valuable research collaborations had nothing to do with a number of papers or the author order. So all of these have given me an opportunity to work with a lot of different authors, and I think it was kind of the science and the human interaction that helped maintain my interest more than where I ended up on the paper. So let me finish up by saying, again, I didn't do a meta-analysis of this or consult patient interest groups. This is based on my experience, and your experience may be different. But my advice is, and by the way, I serve on the Work-Life Balance Committee, so I'm well aware of burnout. But my advice, despite burnout, is say yes as often as possible. In research, as elsewhere in life, communication is key, but so is humility and honesty. Always bring value to your research team. Be careful who you work with, but on the other hand, don't burn bridges. Be a team player and realize that anybody, regardless of how much you value yourself, is not indispensable. Be generous to people below you. And when you publish, place less value on being first or last and more value on the science and on the human relations. Thank you for listening.
Thank you. And next we have Beyond Traditional Communication, Social Media and Residency Programs, Tessa Cook.
Thank you very much. Good morning, everybody. So you might be wondering why, as a physician, you should join social media. And I'll give you 3 reasons. There are certainly potentially more. One is education. You have the opportunity not only to educate your fellow physicians, folks from other specialties, potentially even patients, but also to be educated yourself. I find that, that social media is a very nice way of learning about new publications, cutting-edge research, having a conversation. And the other bonus of this is the ability to engage with others that may not be in close geographic proximity. It's a really nice way of having conversations with folks across the country, folks around the world, people in different areas of medicine, people outside of medicine who are doing relevant work. And for those of you that are heavily involved in advocacy, you know that it is also a great means for engaging on that front as well. So those are just general reasons why, as a physician, you might want to be get involved in social media. But to our specific topic this morning, why should residency programs engage on social media? And you've probably seen this infographic before. It's not certainly specific to radiology, but I think it is very appropriate for our current generation of radiology residents. I don't know if you look around the reading room that you find that your residents engage with each other, even in different reading rooms on different campuses, much more than I even ever did as a resident, and I'm not that many years out of training. They're always on a device that's not the workstation, right? There's a phone, there's a tablet, there's a laptop. They're texting each other about interesting cases. They're asking each other questions. So they are already doing this, even if your residency program is formally not doing it. Social media lends itself very nicely to the way that our current generation of residents likes to learn and likes to explore the field. They get a lot of instant gratification and instant response from it. It really ties very nicely into the way that they learn. And it fulfills that sort of lifelong learning desire as well, and it allows them the opportunity to explore. So it really is a very nice technology for dissemination of information and education. And so there are different ways that you could actually apply it in a residency program. You can use it for education, for sharing information. You can use it certainly for more administrative things like news or announcements, for celebrating awards and honors. But it also potentially has the ability to be used as a recruitment tool so that potential residents interested in your program can get a sense of what life at your residency is like. Now, of course, there are some considerations that you have to take into account. Do you want a social media presence that is actually open to the rest of the world or to the rest of the community, or do you want to keep this exclusively for use by your trainees internally? And that's a big consideration in terms of how you apply some of these uses and also what content you share. HIPAA and patient privacy is, of course, a foremost consideration in social media. At no time should you be posting anything, any kind of protected health information on a social media platform, with the one exception, of course, being a case where a patient has specifically given permission for their information to be shared for a specific purpose. And professionalism is always a concern when you are engaging on social media for any purpose. You may find that there is need for increased oversight to make sure that that the presence is a professional one, that people are engaging appropriately with one another. So we are very fortunate to have a variety of social media platforms at our disposal. And I'm just curious in the audience, how many of you currently consider yourselves actively engaged on social media for any reason, personal or professional? Okay. And how many of you have actually been using it for professional purposes? Okay, so slightly fewer, but still a fair number of hands. That's great. The nice thing about having so many tools at our disposal is you can really pick and choose as to the kind of content that you want to share and find a platform that is most suitable for that particular type of content. So if you're primarily interested in sharing images, you might lean more towards something like Instagram or Figure One, which is actually specifically for medical content. Facebook and Pinterest certainly will do that for you as well. If you're interested in sharing lecture vignettes or other kinds of videos, you might lean more towards YouTube. And many of you have probably noticed that there are a fair few of us engaging on Twitter at this meeting. And I consider myself a fair weather tweeter. I tweet at meetings, but not so much when I'm not at meetings. But there are certainly many others that are much more dedicated to Twitter and keeping the discussion going even when we're not at conferences. So that can be very useful for different kinds of information, but certainly is very supportive of text as long as you're brief. So what I wanted to do this morning was share with you a few successful use cases, and some of these are very easily identified. If you're on Twitter, and these are just two that I happen to choose, you will see content from these groups. The other two were actually examples that were directly given to me that I'll share with you, and I do want to acknowledge Dr. Saad Ranganawala from the University of Cincinnati. He's a resident there that got very heavily involved in their social media presence and has done some really nice work. And also Dr. Alex Memorian, who's a neuroradiologist at Penn, who started an Instagram feed, which I'll show you in a few minutes. So as far as Twitter is very good for both image content as well as text content. And so Cincinnati Children's Radiology has a nice regular feed of educational content that they post on their Twitter feed. Some of it is image-based, as you can see here, with a case that's actually linked out to more details if you click on the URL, but just a little synopsis of a right-sided aortic arch and leftward tracheal deviation and one nice annotated image to go along with it. And certainly anybody consuming this could click on the link and get more information. I noticed recently they're also doing these weekend review nuggets, just factoids that are standalone, that you can actually then click on this weekend review hashtag and see a whole collection of them. So very nice to use Twitter for either text or images or some combination of both. Mass General does periodic tweet chats on different topics. This was one that they did recently on value-based care. And the nice thing is if you're able to engage on Twitter at the time that the discussion is going, you can certainly consume the content at that point. But they also archive it. So the transcript is available at a later date. So this was a week after the discussion actually happened that they were posting about it. And there's also a collection of resources that might have been mentioned at the time of the discussion that has been archived for subsequent consumption. So that's another nice thing about social media is the content is not fleeting. It's not Snapchat radiology. It's not gone in 8 seconds or whatever it is. You know, a lot of this is essentially archived for later use, even if you're not there at the time of the actual discussion. So Figure 1 is somewhat unique in that it is particularly focused on images and pretty much exclusively for medical content. So you may see that as a limitation. You may also see that as an advantage. But it allows users to essentially provide one or multiple images. It actually supports scrolling image stacks, which is very nice for radiology, and allows users to provide a very substantial text complement to the images. If you're active on Twitter, you know that the Twitter limit is an order of magnitude less than this, only 140 characters, whereas you can type significantly more to accompany your images on Figure 1. They do have a mobile platform and are specifically intended for medical content, not exclusively at all to radiology. If you're interested in more, and that slide I should say was from Dr. Ranganawala. If you're interested in more about what the folks at Cincinnati Children's have done, they actually just recently published a paper in Academic Radiology, which talks about their efforts both on Twitter and Figure 1, and possibly also some of their Facebook presence as well. They have a very nice comprehensive program. As I mentioned earlier, Dr. Alex Memorian, who's one of our neuroradiologists, started the Rad Physics Instagram feed. It's a collection of cases as well as artifacts, both from CT and MR. And what Alex does is he'll usually post a case, sometimes with history, sometimes without history, and then anybody viewing the case can actually comment. So in some cases, you know, people actually try to make the diagnosis, and then he'll wait a short period of time, and he will actually give the diagnosis and an explanation as well. So here's an example of a head CT. Here's a brain MR, and in some cases the discussion actually goes on for a longer extent than others, and he gave me some very interesting advice based on his experiences specific to this Instagram feed, but I think is actually very relevant regardless of what social media platform you're trying to engage on. It is important to vary the content. So in Alex's case, he mixes it between movies and images so that there's some variety there. He also tries to combine or alternate between unknown cases and teaching cases. So cases where he just provides the image and waits a bit of time before he reveals the diagnosis, and other instances where he actually provides the images and the diagnosis and the explanation all at once. One thing that he mentioned that, I'll be honest, I hadn't really considered previously was that he was surprised at the size of the international audience that he was getting, and he also had to be somewhat aware of the potential language barrier, and so he adjusted the way that he was producing content as he went on with this initiative. He found that image annotation was very valuable for the people that were consuming the content. Again, a caution about never revealing protected health information online when doing this, and making sure that images are edited appropriately before they're posted. He cautioned against posting sensational content. So in other words, he stays away from the severe trauma cases and things like that, because the goal is to educate and not to not to just post for the sake of shock value, essentially. He did mention that he got some criticism of the site, and every time that happened, he tried to reach out to the individual and say, you know, can you help me to improve? What would help to make this better? And he did occasionally have instances where he had to essentially police the behavior of some individuals on the Instagram feed. So, if you're thinking about trying to get started with this, the easiest way to do it is, they say imitation is the highest form of flattery, is to figure out what's worked for other folks. There are many really great examples of this. I've only showed you a handful this morning. There are also a couple of posters, actually, just next door on the topic of social media and engagement in residency programs. The easiest thing to do is to figure out what your residents are actually using, because I guarantee you they're using something, or possibly multiple platforms and resources, and there may even be one or two that are interested in helping you out with this initiative. It's useful to take a little time and make a plan. Think about what your audience is for this, what the message is going to be, what your goals are in starting a social media presence, and make a plan for some oversight of the content so that it's regularly refreshed, it's monitored for appropriateness and professionalism, etc. And then you go. So thank you very much for your attention this morning. You can find me on Twitter if you have more questions, and I think all of us will take questions now as well. Thank you.
Great. We'll ask our speakers to come up to the front, and if anyone in the audience has a question, please come up to the microphone. Feel free.
Hi, Mark King from Ohio State. I have a quick question for Dr. Cook. Great talks. They were very, very enjoyable. Thanks very much for everyone participating this morning. We've recently been really, exploring the protection of patient information, as of course everybody should. But we've found recently some issues that we were totally unaware of. So issue number one. If an image is cropped, if you put that in a PowerPoint, the information that's cropped out is still available to someone who downloads it. Similarly, if you use an Excel spreadsheet and you put that in a slide, the data behind the cell can be mined. And I love the idea of using social media for teaching file cases, for sending little bits of information. That kind of information, I think, is recalled, very efficiently, very accurately. So the question I have for you is, how do you nuts and bolts level assure that protected patient information is not included in your social media post inadvertently?
That's a great question. To address the PowerPoint aspect of this, so what I always do is I always crop the image outside of PowerPoint and then just put it in the slide. So if it's been edited outside of PowerPoint and you've taken out the parts of it that have protected health information and then you put it in the PowerPoint, you're actually okay.
Are you certain? I'm not sure of that, actually.
Yes. It's when you take a whole image, put it on a slide, and then use the PowerPoint cropping tools. That's the part, that's when it's still discoverable, is that all the image data is there, it's just PowerPoint's not showing it to you. But if you do that editing piece outside of the application, you'll be okay.
Yeah, I've actually been told otherwise, but
That's interesting.
yeah, so I'm
never
not,
had that experience.
I'm not 100% certain. The reason I mention it, obviously, is the penalties for inadvertently doing this are so great that this incredible tool, Twitter, that I think could be just a phenomenal educational tool. I'm just a little bit antsy about doing it.
The other thing you can do, if the safest thing you can do, and you do compromise image quality a little bit in doing this, is to take a picture of the image.
Yes.
Because that picture on your phone, as long as you don't include anything on the screen that is protected, won't carry any of that information over. You do compromise image quality a little bit, but you just it does require sort of a couple of steps ahead of time to make sure that there's nothing on the screen, to make sure that when you export to JPEG and things like that, that there's nothing in the image, and then particularly for ultrasound where you have data burned in, you actually have to crop and do additional work. That is one of the nice things about Figure 1 is because they knew they were dealing exclusively with medical data, they took a lot of time, they invested a lot of time up front to make sure that anything that gets uploaded is protected.
Thank you.
So I actually gave a talk in my department last week about promoting, you can't hear me?
Yeah, just bring it down a little bit. Thank you.
Now?
Yeah.
Yes.
Okay. I actually gave a talk last week in my department on promoting patient and family-centered care and encouraging radiologists to do what a lot of you have encouraged this morning. And particularly, there are those of us in breast imaging or IR or PEDS who routinely talk to patients and families. And I was trying to encourage those outside of those disciplines to do so. And one of the questions I got, which I don't know the answer to, and I'm hoping for an answer from this group, is, how do you know when someone is calling you that they are the patient and not someone posing as the patient? And one of our pediatric, I say, well, we ask them their name and birth date, but one of our pediatric radiologists said, there's a lot of custody issues where that person is not involved in patient care, and how do you know that it's okay to discuss that person's what safeguards can you build in that it's okay to discuss that person's care with them?
Yeah, we do name and birth date.
That's what we do.
That was one of my issues with giving breast biopsy results over the phone, and that's one of the reasons we don't do it. In my practice, I will not give breast biopsy results over the phone. They need to personally come in. But I will discuss imaging studies with a name and birth date confirmation. In breast imaging, if there's a man's voice on the other end, I know I'm not talking probably if it's a woman in the imaging study, but we do name and birth date, and our risk management is okay with that. If they call, it's the same like if a patient calls a nurse in a pediatric practice, like I call my daughter, they just ask my name, my daughter's date of birth, and if I can do that, they'll discuss my daughter's care with me. So that's what regular doctors do, right? Yeah.
Right. I guess he was concerned.
That's standard of care, I think.
If there's a non-custodial parent, they're going to know the name and date of birth, and
I know the way we deal with that in our pediatric department, I know, is that there are warnings in the patient's medical record that say the patient information is not to be discussed with mom or dad or whoever the parent, and I know we do that at our institution. So that's one way to do it, and that usually just arises in pediatrics, because otherwise only with the patient, their own date of birth and everything. But there can be a warning put in a chart saying, or a medical record saying, you are not allowed to talk to X person.
Thanks.